The following podcast is part of a certified educational activity titled Precision Learning for Precision Medicine. What you need to know about hitting the type 2 target with biologic treatment for chronic rhinosinusitis with nasal polyps. Access the entire activity and complete the post-test at peerview.com/ZEC860. Downloadable slides and practice aids are also available.
I'm Dr. Stella Lee. I'm the director of the Brigham Sinus Center at Brigham and Women's Hospital. I'm a rhinologist and otolaryngologist in Boston, and I'm joined by my colleague, Dr. Kathleen Buchheit.
Thank you so much. I'm Kathleen Buchheit. I'm an allergist immunologist at Brigham and Women's Hospital and Harvard Medical School. And today we're going to talk about precision learning for precision medicine, what you need to know about hitting the type 2 target with biologic treatment for chronic rhinosinusitis with nasal polyps. Our goals for today are to help you recognize the signs and symptoms of chronic rhinosinusitis and the clinical relevance of comorbid diseases of type 2 inflammation, improve your ability to identify patients with chronic rhinosinusitis who may be candidates for biologic treatment. We want you to know how to integrate biologics into the chronic rhinosinusitis with nasal polyp treatment plans as appropriate. And lastly, how to assess patient response to their treatment.
Let's talk about defining and recognizing CRS with nasal polyposis. Evaluation diagnosis of CRS is based on symptoms as well as objective findings. Patients must have symptoms for at least greater or equal to 12 weeks or 3 months, and symptoms include drainage, which can be anterior or posterior, blockage of their nose, facial pain, pressure, and hyposmia or anosmia, which is loss of smell. Symptoms alone are not enough to make the diagnosis. We also need an objective finding, such as endoscopic inflammation, seen as you can see here, nasal polyposis, or edema of the mucosa. Another objective finding that is commonly utilized is a maxillofacial CT scan, which shows bilateral diffuse inflammation of the paranasal sinuses. CRS with NP has multiple subtypes, as you can see here on the right-handed picture. There are multiple variations, including patients who have AERD or aspirin-exacerbated respiratory disease, allergic fungal rhinosinusitis, eosinophilic mucin rhinosinusitis, and there's other diseases that we won't go into, but it's important to be aware because these patients who have, for example, primary ciliary dyskinesia or cystic fibrosis can also present with polyposis or without polyposis. CRS with nasal polyposis is an adult onset condition. And as you can see here, patients with AERD sometimes present younger than patients without AERD. Some of those important phenotypes, as I mentioned, that are different from just the typical patients who have CRS with nasal polyposis have the more severe phenotype or endotype of AERD, and also in different geographic locations, such as in the South and in different parts of the world, we see allergic fungal rhinosinusitis. Dr. Buchheit, can you speak a little bit about patients who have AERD and what your observations are of these patients?
Yeah, so these patients, have often nasal polyps with comorbid asthma and then comorbid hypersensitivity reactions to aspirin or NSAIDs. And they have really severe nasal polyps that sometimes will quickly come back after, really excellent endoscopic sinus surgery.
And as you can see here, these are the symptoms that patients suffer from. It greatly diminishes their quality of life. Nasal symptoms, as you can see here, the blockage, congestion, the loss of smell. We do know that the two symptoms that really are very important to patients are the ability to breathe through the nose, so nasal blockage and loss of smell. So I want to point that out. But patients can also have other symptoms like ear symptoms, eustachian tube problems, and then comorbid to that, anxiety, depression, problems with cognition, sleep, and associated daytime fatigue. Let's talk about the prevalence of type 2 inflammatory comorbidities. And it's important to realize that a large proportion of patients with CRS with nasal polyps may have comorbid asthma. And Prevalence of asthma in the general US population is about 8.5%. It may vary depending on the population studied and the research that is currently being done. But we do know that it is one of the most important comorbidities to CRS with NP, and it's adult onset asthma rather than childhood onset asthma. We do know also that this endotype of patients who have comorbid asthma have more severe disease, as Dr. Buchheit mentioned, and up to 26% of patients with CRS with NP also have comorbid aspirin-exacerbated respiratory disease. There's a nice study done at Northwestern that shows exactly that point, that patients who have CRS with an NP alone compared to patients who have CRS with NP plus asthma, compared to patients who have CRS with NP and the endotype of AERD, the patients with AERD seem to do the worst. As you can see here, the patients who have radiographic severity, the number of sinus surgeries that need to be done, as well as the dependence on corticosteroids. Of all CRS with NP comprises a fraction of all of patients who have CRS. So as you can see here, about 20 to 30% have nasal polyposis. And these patients often have high tissue eosinophilia. They're T2 predominant. In the US, we see that, and also in Europe. And this may also vary depending on where you are in the world. But the other vast majority of patients actually don't have polyposis that's obvious, but this may be a spectrum, and we are really beginning to better understand the different types of inflammation, type 1, 2, and 3. And these patients may have less eosinophilic infiltration or mixed inflammatory subtypes. It's really important that we recognize AERD early, and past reactions to any kind of NSAID should be, these patients should be evaluated for possible AERD.
So we're now going to talk about considering the role of type 2 inflammation in chronic rhinosinusitis with nasal polyps. So type 2 inflammation is the predominant driver of chronic rhinosinusitis with nasal polyps. So what does that mean? It means that type 2 inflammatory cytokines like IL-4, IL-5, and IL-13, which are really canonical type 2 cytokines, often drive a lot of the underlying immune pathology. And we see that nasal polyps are filled with cells like eosinophils, mast cells. There's certainly a role for basophils, M2 macrophages, really driving inflammation. There's also a role for IgE production locally at the nasal polyp tissue, which in turn can influence both basophil and mast cell activation. And we think that really a lot of the inflammation starts with the dysregulated epithelium and innate cytokines like IL-33 and TSLP driving that downstream type 2 inflammation. And we see really other type 2 diseases such as asthma is often occurring in patients with chronic rhinosinusitis with nasal polyps as well. So many of the therapies we use specifically target these drivers of type 2 inflammation. Corticosteroids do it in a non-specific way, but now we have more specific targeted therapy. So biologics targeting IL-5, which include mepolizumab, are used in treatment of chronic rhinosinusitis with nasal polyps. Dupilumab, which targets the interleukin-4 receptor alpha and can block signaling of both IL-4 and IL-13, is a treatment for nasal polyps, as is omalizumab, which targets IgE. So in terms of treatment of chronic rhinosinusitis with nasal polyps, this is really a chronic disease process that requires long-term medical treatment. And sometimes initial first-line medical therapies are ineffective, and surgery may be required at that point to remove nasal polyps. Dr. Lee, you can kind of speak to that, but tell us a little bit about how you see surgery kind of playing a role here and what patients must try and fail first.
Yes, thanks, Dr. Buchheit. Functional endoscopic sinus surgery is quite effective and safe, elective procedure. And for patients who are suffering quite a bit and the medical therapy has not been effective, then endoscopic sinus surgery is very well tolerated and can be a good choice for some patients who have refractory nasal polyposis despite the medical therapies.
Yeah, that's great. Yeah, usually when I see patients with nasal polyps, I will refer them to my colleagues in otolaryngology for, good endoscopic nasal exam, as well as discussion of functional endoscopic sinus surgery. So traditional treatment approaches include nasal saline irrigations, topical intranasal steroids, which there are a variety of different delivery systems that can be trialed. Antibiotics may be useful, certainly in treating acute infections, but evidence for long-term use is really clinically lacking. Leukotriene modifiers can be helpful in patients with aspirin-exacerbated respiratory disease specifically. And then systemic corticosteroids can be quite effective, but really should only be used on a very short-term basis given adverse effects. So just looking at kind of drivers of type 2 inflammation and what the currently available biologic medications target, we see that they have a variety of different cellular targets that I think can explain a lot of what they're doing from an immunologic basis for patients with nasal polyps. And again, to reiterate, the currently available biologic therapies that are approved for chronic rhinosinusitis with nasal polyps include dupilumab, omalizumab, and mepolizumab. But there are also other indications that these biologics are approved for. So it's important when considering patients with comorbidities, you may want to choose one biologic that can target multiple different diseases.
In this segment, we will be identifying candidates for treatment with targeted biologic therapy. We want to best identify those patients who may be the best candidates for biologic therapy. And there are criteria that are published. There are multiple documents out there. One of these is the European position paper on sinusitis as the euphoria criteria. And as you can see, there are different criteria on the left-hand side. Patients should have bilateral polyposis, and potentially they may have or potentially not have had surgery, but the consensus was that it is ideal if patients have had at least one good sinus surgery, and that there are certain criteria such as type 2 inflammation, the patients respond to systemic corticosteroids, or perhaps they can't take systemic corticosteroids, they have impaired quality of life, they have loss of smell, and comorbidities are also important, definitely asthma. And then when you look at the cutoff points, these are not set in stone, but these are meant to be guidance for what we can think of as potential future biomarkers, because we don't have a biomarker per se as of now, but perhaps we can use these cutoff points as clues that these patients are type 2. Patients should have disease severity that we can measure, such as the sinonasal outcome test with 22 questions that's greater or equal to 40. Perhaps they can't smell if we do an objective or semi-objective smell test. And in case of asthma, if they are really not controlled or they really have a regular need for inhaled corticosteroids. There's a nice guidance and some manuscripts out there. This study looks at all the different options available for patients who have CRS with NP. And at the top, you can see the first line therapies are intranasal corticosteroids and nasal saline irrigations. We really try to emphasize that patients should at least give these a try because it's surprising. If you do some of these very basic things, patients do feel a lot better, but it has to be consistently done. And another interesting thing here, as you can see, are different phenotypes and endotypes of CRS with NP, CRS without nasal polyps, as well as allergic fungal rhinosinusitis. And especially for aspirin-exacerbated respiratory disease, that aspirin desensitization is an option. And then for allergic fungal rhinosinusitis, some second-line therapies that are available to those patients. I think this is a nice summary slide. There was indirect treatment comparisons done on the different biologics and different therapies. As you can see here, aspirin desensitization was also included on the left-hand side. And green means that there was significant data that shows that it was probably among the most beneficial And then red is probably there's some potential harm. It does look at different biologic therapies. And it's important to keep in mind that all these biologics do target different parts of the type 2 inflammatory pathway. And on the top, you can look at different patient-reported outcomes that are such as health-related quality of life, symptoms, smell, the need for rescue steroids, the need for surgery, as well as some of the surrogate outcomes such as nasal polyp score, or what we call NPS or CT score. We often think about for our patients whether they would do better with a biologic, or they would do better with a functional endoscopic sinus surgery, or perhaps this patient might need both. There's a lot of discussion and controversy over whether a biologic should be started first or sinus surgery should be done first. I think still there's a lot of research that needs to be done and real world evidence before we can really recommend one should be done before the other. But in general, my thoughts are that now we have multiple options now for patients with the most severe disease, which is wonderful. And it would be reasonable to consider biologic therapy for patients who have a really severe disease, history, they've had surgery, they had rapid recurrence of polyposis after surgery, they may have comorbidities, and sometimes patients really have a strong preference for one or the other. And I'd like to ask Dr. Bucay too what her thoughts are and how she navigates this, because I know this is on the top of everyone's minds when faced with patients with a challenging polyposis.
Yeah, no, this I think is a really great point. I see a lot of patients who have aspirin exacerbated respiratory disease. And, these patients often, but not always, can have, recurrence of nasal polyps after surgery, even if they're doing all the, right medical therapies associated with it. And I think that really trying to identify patients who have really, evidence of severe inflammation or severe asthma, who have, comorbidities where they would benefit from a biologic regardless. It's important to identify and capture those patients to see if we can really, use one medication to treat multiple problems. And in those patients, I think there are cases where it's really appropriate to consider biologic therapy instead of, in addition to or instead of endoscopic sinus surgery.
Great. Thanks so much for your insight. And that's why it's so wonderful to be able to work as a multidisciplinary team to best take care of our patients.
So we're going to now talk about a closer look at targeted biologic therapies for CRS with nasal polyps and look at some of the trial evidence and real-world experience. So there are currently 3 medications that are biologic medications approved for treatment of chronic rhinosinusitis with nasal polyps: dupilumab, omalizumab, and mepolizumab. In terms of the co-primary endpoints from the study of dupilumab compared to placebo for chronic rhinosinusitis with nasal polyps, we see that over a 52-week period, dupilumab led to a reduction in the endoscopic nasal polyp score, which means the polyps shrunk and got smaller during this time frame, and that patients also felt better at the same point. So they had less nasal congestion or blockage and could more easily breathe in and out through their nose. We also see that in this study, dupilumab led to patients who were treated with dupilumab had less need for surgery, for sinus surgery, or for treatment with systemic corticosteroids compared to the patients who received placebo. And that in addition to the improvement in their nasal polyp symptoms, there was also impact on asthma control. Patients treated with dupilumab had improvement in their FEV1, so improvement in lung function, and then also improvement in asthma symptoms, as evidenced by the ACQ-6 here. And then again, looking at a sort of post hoc analysis, we see that patients who had CRS with nasal polyps with comorbid asthma, who were treated with dupilumab compared to placebo, again had reduction in systemic corticosteroid use and fewer asthma exacerbations. So in terms of omalizumab, which is a monoclonal antibody that blocks IgE or targets IgE, studies Polyp 1 and Polyp 2 also showed efficacy of this medication for treatment of chronic rhinosinusitis with nasal polyps. Again, we see over the 24-week treatment period here in studies Polyp 1 and Polyp 2 that there was, again, reduction in the endoscopic nasal polyp score, and then also reduction from baseline in the nasal congestion score. And then during the open label extension treatment period, everyone who received the drug had benefit in terms of, both groups had benefits in terms of reduction in nasal polyp score and nasal congestion score. And then after withdrawal of the omalizumab, we see that there is recurrence of some of the nasal congestion symptoms and an increase in the nasal polyp score. For this study, which is called the SYNAPSE study, which looked at mepolizumab versus placebo for treatment of chronic rhinosinusitis with nasal polyps, we see that in terms of the total endoscopic nasal polyp score and then the nasal obstruction visual analog scale score, that patients who received mepolizumab versus placebo were more likely to have improvement in both the nasal polyp score and the nasal obstruction score. And in more recent data, looking at the 52-week treatment period followed by a follow-up period with no drug for from weeks 52 to 76, we see that the benefit of mepolizumab, which targets IL-5, is sustained here for this week 52 to week 76 treatment period compared to placebo. So there may be some ongoing benefit after discontinuation of the drug. There are currently additional biologics, which are in phase 3 trials for chronic rhinosinusitis with nasal polyps. There's benralizumab, which targets the interleukin-5 receptor. There's a long-acting anti-IL-5 called depemokimab, which is in studies. And then tezepelumab, which targets TSLP, is also in study for chronic rhinosinusitis with nasal polyps. So we'll have more information about these drugs in the future. So in terms of comparing biologics in the absence of head-to-head trials, there have been there's no data from head-to-head trials comparing dupilumab to mepolizumab to omalizumab. It is helpful to look at network meta-analyses, which compare the results of multiple RCTs. And again, there are certainly limitations to these studies, as there were some important differences in the study population for the different trials that were done. But looking at this, we see that when looking at a variety of both patient-important outcomes and surrogate outcomes, that dupilumab ranks as among the most beneficial with good quality evidence in 7 of the categories. Omalizumab ranks as among the most beneficial in 2 of the 7 categories, and then mepolizumab ranks as among the most beneficial in terms of the symptom VAS. So there may be some differences, and I think going through this information with patients is important when selecting a specific biologic therapy. There's been a indirect treatment comparison. I'm looking at dupilumab versus omalizumab, which again has limitations, but does show that compared to omalizumab in terms of both the nasal polyp score and nasal congestion score, that we see that there is overall favoring of dupilumab versus omalizumab in this study. And there will be more data to come here. There is currently a phase 4 study, which is comparing dupilumab versus omalizumab for patients with comorbid chronic rhinosinusitis with nasal polyps and asthma. So that data will be coming available. So more to learn here.
So let's talk about practical considerations in initiating use of targeted biologic therapies in CRS with nasal polyposis. It's so important to engage patients in shared decision-making. And as physicians, I don't think any of us took a course on shared decision-making, but it's so critical for patients to understand and to also participate in the process, to provide all the options available to patients, including the pros and cons of different treatments, including the risks and side effects, help the patient understand and evaluating those options, and help with the decision-making process. And then implementation also in this current environment that we live in. It's really difficult sometimes for us to make the decision, but then for the patient to not be able to get the treatment because of outside factors. So overall, shared decision making is really important. And as you can see here, some topics to discuss, including what current patients are on as far as medicines, or what they've tried, and medicines that have been tried and have not worked for them, surgery, comorbid conditions, symptoms, quality of life, and their likelihood of adhering to a certain treatment option. I'm really I think it's good to have an honest conversation of what patients are willing to do on a daily basis, because this is a chronic condition as of now that we don't really have we don't have a cure for. Here we show that patient choice is really important. When patients have tried everything, intranasal corticosteroids, saline rinses, systemic corticosteroids, and of course, if they have a good treatment response with the mainstay treatments, then that's great. However, if there's inadequate response, there is a surgical option, and that discussion of what sinus surgery can and cannot do for patients is really important, that it is an adjunct to treatment, because sinus surgery is also not a cure for polyposis. And I think that's a common misconception among patients. And of course, if they don't want to have sinus surgery because there's either a contraindication or they do not want to have sinus surgery, there are alternative treatments available, including different types of in-office steroid-eluting stents and biologic treatments. And so the question is, should biologics, when should we recommend that biologics be used in the shared decision-making process, and what patients might be the best ones that would have the best outcome? It would be great if all of our patients were super responders to the treatment option that we choose. But as of now, we don't really have that prognostication available to us. So it's reasonable, I think, if the patients do have high disease burdens, stage 4 polyps on each side of their nose, they've been really trying these intranasal corticosteroids, but they have not been working, and they have comorbidities, I think that would be a reasonable indication for biologic therapy. I'd like to ask Dr. Bukai too what she thinks regarding these practice parameters and how she practices and with her patient population.
Yeah, I think that the practice parameters certainly give a nice summary of the evidence and a good framework for how to consider this. But there's so much, I think, nuance depending on the individual patient in front of you. So I really try to approach each case, as you do, it's a unique patient, kind of what they're looking for and what their goals are to achieve. So there's a lot of variability, and I think a lot of unanswered questions too, and in terms of really how to most effectively implement these therapies.
And there are 3 biologics approved for CRS with nasal polyposis: dupilumab, omalizumab, and mepolizumab. And there are other indications that these medications are also approved for. So it may make sense to be aware of these comorbid conditions that may allow you to select the best biologic depending on the patient's other conditions besides the CRS with NP. There are still several unmet needs, and according to EPOS and Euphoria, as we can see here, biomarkers are still needed. We currently do not have a biomarker to prognosticate and determine which therapy is best for which patient. So we need to identify those biomarkers related to CRS with NP, and hopefully that comes with better understanding the disease pathomechanisms as well as disease processes, as well as the positioning of biologics in the treatment pathway, since there's multiple algorithms that currently exist. But we do need better, well-designed randomized controlled trials and real-world data to better define where biologics should fit within the algorithm. There's some interesting trials being done in Europe looking at the combination of biologics such as mepolizumab as well as in-office polypectomy, looking at the change in patient-reported outcome measures as well as the polyp severity and the need for rescue systemic corticosteroid use. There's a The second trial here is showing also they're looking at mepolizumab alone versus mepolizumab and sinus surgery and looking at those outcome measures as well. So a lot of interest in determining whether you can combine treatments and then achieve a better outcome for patients. Another interesting trial is looking at recurrence, and all of us are very concerned for patients who, despite our best efforts, we do the sinus surgery, we do the biologic, we start the patient on biologic therapy, and they still have recurrence of symptoms and polyps. And so this study is looking at that question particularly. And I wanted to ask Dr. Buchheit, because I know she's doing some incredible work on this topic as well, on looking at recurrence.
Yeah, we're really interested, I think, in identifying biomarkers that are, really reliable to help determine, which patients are at high risk of having recurrence after sinus surgery, and considering, whether or not to employ surgery plus biologic therapy together in those patients versus, would those patients be more appropriate for biologic therapy instead of undergoing functional endoscopic sinus surgery. So I think that there is, really active area of research and so much more that we can learn here to help our patients.
Great. Looking forward to the results. And then I'm going to turn this over to Dr. Buchheit to talk about some practical considerations.
Yeah. So, when prescribing biologics, really carefully talk about risks of medications, known side effects that patients might expect and to look for, and, what to do if that were to happen, kind of when to reach out to us. We'll often say, if anything unexpected happens or anything that you're concerned about, you should let us know, and we'll talk about what to do. And, certainly for patients who self-administer at home, which is many of our patients on biologics, we do, or our nurses will do some injection teaching with patients. We talk about how to safely store the medications in the refrigerator and sort of taking them out in advance so they come up to room temperature. Prior to the injection. It makes it more comfortable for them. And then we talk with them about sort of any barriers to adherence with the medication. Oftentimes when it's working well, they really do want to stay on their biologic medications. But, certainly sometimes cost can be a problem, and working with patients to best achieve, again, their health goals is something that we work a lot on. So we'll be talking now about beyond initiation, monitoring ongoing use of targeted biologic therapies in chronic rhinosinusitis with nasal polyps treatment. So after a patient has started on biologic, it's really important to maintain close communication with your patient and see them regularly to really evaluate for response to biologic therapy. In a set of European guidelines looking at response to biologic treatment in chronic rhinosinusitis with nasal polyps, it's really recommended to look at criteria such as reduction in nasal polyp size. That's something that is going to require a physician to examine the patient. Very importantly, reduced need for systemic oral corticosteroids. That's really a major goal of treatment that can reduce risks associated with systemic oral corticosteroid exposure in patients. We want our patients to feel better. We're looking at quality of life measures in them. A huge benefit of these therapies is that it can lead to improvement in sense of smell. So that's certainly something that we'll ask our patient about. And then we want to know about reduced impact in comorbidities, things like asthma, or if patient has comorbid skin disease that the biologic may also manage. We're looking for improvement there as well. And, some patients will have rapid, improvement in symptoms after, less than a month or 3 months, but we typically will give medication about 6 months and make sure that treatment response is evaluated after that time. And if we're not seeing any response at all in a 6-month time frame, we'll often discontinue treatment and come up with something else. After 6 months, we also recommend evaluating response after 1 year. And again, discontinuing the treatment if there's no response in any of the criteria there. Again, in clinic, strategies to assess treatment response that can be helpful. Looking at the nasal polyp score via endoscopic exam can be helpful. In patients with comorbid asthma, looking at their lung function, sometimes measuring FeNO can be helpful. Using some of the patient-reported outcome measures, such as the SNOT-22 score, is helpful. you can ask patients certainly about their nasal congestion or obstruction, ask them about their sense of smell, and using some of the scores can be helpful as well. There are also measures that are used in clinical trials that, aren't necessarily things that are done in a clinic setting, but these are listed here just so that you see what they are. So there are still areas of unmet need in terms of defining how we use these biologic medications in clinical practice. Specific things that need further study are duration of therapy, and that might include well-designed randomized clinical trials or real-life data studies. Definition of remission. So what does it mean? What do we call a success? And again, I think real-world data and registries will be helpful for this. We also really need to identify and define criteria for switching biologic therapy. Again, I think a lot of this will come out of real-world data that's currently being collected. And then further defining what the feasibility of prolonging dosing intervals for these drugs. Looking at that more carefully, again, with real-world data and registry is going to provide additional evidence for spacing out the dosing interval and seeing, which specific patients may benefit from that and do well with that. So, how do biologics really change how we think about chronic rhinosinusitis with nasal polyps? I'll start with the first bullet point, which is, how does it change how we think about the disease and what it means? I think the use of biologics really highlights that this is an immunologic disease. It's not just a sort of mechanical problem or an anatomic problem. These are inflammatory polyps. And given that the current biologics that we have available really target type 2 inflammation, it brings up an important point of really trying to do some endotyping to understand what immunologic pathway is driving the patient's underlying inflammation. For most patients with chronic rhinosinusitis with nasal polyps, it's type 2 inflammation, but I think that we really need to be thoughtful about what is driving our specific patient's underlying disease. Dr. Lee, I was hoping that you would talk a little bit about the definition of remission, control, cure here.
Yes, absolutely. So we met with the Euphoria team and also with the EPOS team, and this comes from the European group, and these are some nice definitions because we really did not have clear consensus on what control of symptoms meant. What remission means, what remodeling means, what cure means. But just to go over briefly, control means absence of symptoms in the last month. So it's absence of nasal congestion, drainage, facial pressure, hopefully that their smell overall is improved and that the patients are feeling well. Remission is a new concept for us, and it's interesting in the field of rheumatology. They've been using this definition for over 40 years, but we are just beginning to understand and define this. And as you can see here, remission is defined as no symptoms and patients are doing well and there's no active signs of inflammation for at least greater or equal to a month. Greater or equal to a year. And this can be on treatment. So that's an important point. And we are setting the bar high. So cure is defined as sustained remission for 5 years, greater than 5 years. And hopefully this is completely off treatment. And so that is the important point for cure. But in general, I think we do need to better understand the mechanisms of CRS with nasal polyposis and how it relates to lower airway disease as well, and how to best choose those patients for the right treatment options.
Great. Thank you so much. So I think really interesting discussion and a lot more that we have to learn about managing patients with chronic rhinosinusitis with nasal polyps, and hopefully to achieve that remission and cure point down the road.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/ZEC860.